Thanks, Paul. So I'm going to be speaking about using qualitative evidence synthesis to inform policy in HIV retention and adherence. In 2014, UNAIDS set an ambitious target to eliminate HIV by 2020. They wanted 90% of all people living with HIV knowing their status, 90% of those needed to be on ART, and 90% of those needed to be virologically suppressed. So for this talk, I'm going to focus on the last 90 of that HIV continuum of care. That last 90 is probably the most difficult of the three. Keeping people on antiretroviral therapy, keeping them adherent and in care lifelong is extremely challenging. And as you can see, in 2016, most of the countries on that map have less than 50% of the people living with HIV having a suppressed viral load. And a lot of interventions have been directed at trying to maintain people in care and on ART. And that's well illustrated by this network meta-analysis by Cantus et al., which looked at different interventions aimed at improving adherence to antiretroviral therapy. Now, the diagram's quite hard to see, and you can't see what all those interventions are, but essentially they looked at cognitive behavioral therapy, SMSs, telephone reminders, other kinds of device reminders, incentives, all different interventions to try and improve adherence to antiretroviral therapy. And the take-home message from this slide is that when you look at that forest plot, you can see that not a lot of these interventions were actually effective. And we can conclude that, and it's the same conclusion that the authors had. We need more unique research methods when we look at HIV. And that approach has been the Cochrane approach. We look at interventions and we try to solve the problem looking at randomized controlled trials, but this may not be good enough. So we had a look at the literature. We went back and we looked at qualitative studies, mixed method studies, other systematic reviews to see what have they said, why are patients not coming for care? And we found a lot. There's a ton of material out there and a lot of studies which list the different barriers and facilitators that exist. And we came up with this framework which sort of maps the HIV continuum, linkage, retention, and adherence, and in the sort of biopsychosocial model lists all these different factors that come up again and again in all these studies. And these are essentially just broad categories describing the reasons why people don't come for antiretroviral therapy. And as you can see, across the different domains, the reasons are quite similar why people don't link, why they don't retain or adhere. But when we looked at this, we wondered whether this was really adequate. Does this really explain why a person doesn't come for care? Because if this is it, then we can design interventions targeting each of these. We felt that there's probably more complexity. There's more interaction between these components. How do these link? How do they modify each other? What is the depth of the relationship between all these factors? There needs to be a little bit more about why people don't come regularly. So we decided to undertake a qualitative review, and we're still in progress. At the moment, we have 166 included studies, and a few themes are starting to emerge slowly. And I'm going to share with you just two of those so that I can illustrate how qualitative evidence can give us a richer understanding of what's really going on here. The first theme I want to talk about is this idea of a tipping point. I've put a quote here, and it's essentially a patient who went back to the clinic repeatedly to get a CD4 count, wanting to start antiretroviral therapy. But there was some logistical problems, administrative problems, and he never got his CD4 results, and he never got any medication. In addition to this, he spent a lot of time and money getting to the clinic, and he also felt that he was in fairly good health, and he disengaged from care. Now, when you look at this, it wasn't one event that caused this person to disengage from care. It wasn't that the clinic was too far. There's a series of things that happen, and there are numerous quotes like this, where there was several events, whether they're structural, related to the clinic, or whether they're personal and psychosocial. Several things have to happen for a person to disengage for a long period of time. And this leads into my next theme that's coming out and sort of shouting at us. It's that retention is a dynamic process. People who are adherent today are non-adherent tomorrow. This is not a static process where we can label people as adherent or non-adherent. There's constantly change, especially in low and middle income countries. People's lives are constantly changing. There's multiple things happening, and they're constantly having to weigh up and make choices about coming to the clinic or going to work or dealing with their sick uncle. There's a lot of very difficult choices that people have to make, and it causes them to drop out of care and return. The quotes that I've put here, the first one is an actual quote, and it illustrates how this patient has an intention to return, and most patients do have an intention to return at some point. However, it's not convenient for them right now. They're working. He might have to change his life and maybe get an office job if he really wants to go back, is what he says. But the take-home message here is that many people, they want to return. They don't always want to be out of care. It's just that they have to choose constantly, and that retention is it's constantly changing. People are coming and going. If you look at the second, it's an excerpt from one of the papers, and it discusses women who, after divorcing a partner, returned to care, or they moved closer to the clinic and then they returned to care. And essentially, people are coming and going. And this is something that health services need to understand. And when we're designing interventions, we need to think about how we can minimize this or how we can work with it. That if people are going to be on antiretroviral therapy for decades, there is going to be this constant process of people leaving and returning to care. And we somehow have to adapt our services or our medication or some other aspect of our intervention to deal with this. So those are just two themes, and it seems that we're getting quite a lot of rich stuff when we look at these qualitative studies. But I think they illustrate quite well why it is that when they did that network meta-analysis and they looked at the intervention of SMS reminders, it wasn't adequate. Even though a person may say the reason they don't return to care is because they forgot to take their medication, in reality, there's so many other things happening at the same time. So qualitative research, I'm not saying that we're going to be able to develop the perfect intervention if we use qualitative research, but it can give us an idea of the things we need to consider when we look at HIV, because it's more complicated than looking at, say, effectiveness of antihypertensive medication. So essentially, I think I've laid the case for qualitative research in HIV, and I think what we're trying to do at the Cochrane Infectious Diseases Group and at Stellenbosch is try and use other research methods to try and look at adherence interventions and retention interventions. And I'm going to give you a quote from Paul Garner, which he said to me recently, which is, "We are not slaves to the randomized controlled trial." And I think it illustrates our point quite well. Especially with HIV, we need to use all our research methods. He's a little bit embarrassed. We need to use lots of different methods to try and look at what is actually quite a complex process. Thank you.
Thank you, Ingrid. So we have a time for a few questions or comments. Just give an opportunity for the audience if there's anything that you would like to ask. Thank you. So we've got one person. You can go ahead.
Hi, Ingrid. My name's Hugh Waddington. I'm with Campbell International Development Group and 3IE. Very nice presentation, and particularly glad to see Infectious Diseases Group registering. As I understand it, it's a standalone qualitative evidence synthesis. So kudos to you. Very, in a situation of like real world implementation of complex intervention framework, whatever you want to call it, the qualitative evidence seems extremely important. So my question was, are there any similarities or in developing your framework, were you informed by any other areas of clinical studies where it is known that there are problems in maintaining adherence? For example, the mental health medication, antipsychotics, and things like that? Have you, are you drawing on that?
Thank you. No, we actually haven't drawn on studies from different disciplines. We've mostly been looking at HIV. There's quite a wealth of information out there because it's quite a big research area, but I think that's a good suggestion, just to broaden our perspective on adherence for other chronic medication. Thank you.
Excellent. So let me just check if there's any other comments or questions. Okay, I think we're fine. Ingrid, thank you very much.